Hey everyone, and welcome to today's Explainer. I am incredibly excited to share this one with you because we're going to look at human physiology in a way that just makes absolute logical sense. So, I want you to imagine the female reproductive system as a finely tuned, highly synchronized assembly line. When everything is working perfectly, the end result is a regular menstrual cycle. But what happens when that final product just goes missing? Well, today we are going to play medical detectives. We're going to completely break down the pathophysiology and the diagnostic evaluation of a condition called amenorrhea. And we're going to do it using this brilliant four-compartment framework. All right, let's get started. So here is the roadmap for our investigation today. First, defining amenorrhea. Second, breaking down the four-compartment suspects. And finally, the three-step diagnostic investigation we use to actually crack the case. Okay, let's dive right into this by clearly defining our main symptom. Amenorrhea simply means the absence of menses, but medically speaking, we split this up into two distinct categories. Primary amenorrhea is when a patient has literally never menstruated. We define this as the absence of menses by age 13 if there's no normal growth or secondary sexual development, or by age 15 even if normal growth is present. Now, on the flip side, secondary amenorrhea is when menses cease in a woman who was previously menstruating. Specifically, this means she's missed 3 cycles or gone 6 consecutive months without a period. And what's absolutely fascinating here is the sheer contrast in how often this happens. While it affects about 3% of the general population on average, that number can jump to a staggering 100% under conditions of extreme physical or emotional stress, and even up to 50% in competitive runners. Now hold on, before we bring out the magnifying glass and dive into all these complex anatomical and hormonal investigations, there is an absolute golden rule. Step 0. Literally, the very first thing any clinician has to do when evaluating a missing period is this: always rule out pregnancy. Seriously, it is by far the most common physiologic cause of secondary amenorrhea. So once we run a simple HCG test and confirm our patient isn't pregnant, that's when the real detective work begins. And this brilliantly illustrates how we do it. Instead of trying to memorize a chaotic list of dozens of random diseases, we organize the reproductive axis into 4 distinct compartments. Compartment 1 is the outflow tract. Think of these as the physical exit doors. Compartment 2 consists of the ovaries, which are our factory floor. Compartment 3 is the anterior pituitary gland, kind of like middle management sending out signals. And finally, compartment 4 is the hypothalamus, the ultimate control center up in the brain. If menses are missing, the breakdown absolutely has to be in one of these 4 compartments. Compartments 1 and 2, the doors and the factory floor. Let's start our investigation right from the bottom up, looking first at the physical reproductive structures. So think about it. If the factory is producing exactly what it should, but the final product never actually appears, we have to see if the doors are locked. This is compartment 1, the outflow tract. Disorders right here account for about 20% of primary amenorrhea cases, and usually it's due to congenital obstructions. This includes things like an imperforate hymen or Müllerian anomalies, like a transverse vaginal septum. In really severe cases, we might see MRKH syndrome, which is the complete absence of the uterus and vagina, also known as Müllerian agenesis. Right here, we can actually visualize one of these anatomical blockages. Specifically, we're looking at a transverse vaginal septum. Pathophysiologically, this happens during development when the Müllerian-derived upper vagina just fails to properly fuse with the urogenital sinus-derived lower vagina. So the menstrual blood is actively being produced, but it's physically trapped. It can't get out, a condition known as cryptomenorrhea. Now, if we check and the doors are wide open, we move our investigation up to the factory floor. Compartment 2, the ovaries. And honestly, this is our prime suspect. Ovarian issues are responsible for a massive 50% of primary and 40% of secondary amenorrhea cases. The biggest culprit here is premature ovarian failure, or POF, which affects about 1 to 5% of women before the age of 40. The ovaries just essentially stop working early. This could be due to idiopathic reasons, autoimmune ophiritis, or even iatrogenic causes like chemotherapy, radiation, or surgical removal. But here is where the mystery actually deepens. What happens when we inspect the factory floor and the exit doors and everything is perfectly healthy and intact? They are ready to work, but upper management just stops sending the signal to produce. Compartments 3 and 4, the control center. This brings us to the really fascinating realm of neuroendocrinology, traveling right up into the brain to investigate the pituitary and the hypothalamus. Compartment 3 is the pituitary gland, sitting right there at the base of the brain. When it fails, that vital hormonal communication loop is completely severed.
This accounts for roughly 20% of secondary amenorrhea cases. The most common villains here are actually pituitary tumors, specifically prolactinomas. But we also have to look out for space-occupying lesions or tissue necrosis. A wild example is Sheehan syndrome, where a severe postpartum hemorrhage literally starves the pituitary of blood, causing severe infarction.
Now, what's really interesting about this is how it perfectly maps out functional hypothalamic amenorrhea in compartment 4. Severe stress, a BMI dropping below 19, psychological eating disorders like anorexia or excessive exercise, they all trigger the brain's stress response. Your body sees an increase in CRH and cortisol and releases endogenous opioids like beta endorphins. This perfectly, and I mean perfectly, suppresses the pulsatile release of GnRH from the hypothalamus. As a result, LH and FSH levels drop, and ovulation just shuts down. It's literally the body's protective mechanism saying, hey, we do not have the energy reserves right now to support reproduction. The diagnostic investigation, resolving the mystery. All right, we've identified our 4 suspects. Now it's time to shift from just looking at them to actually conducting the investigation. How do we quickly pinpoint exactly which compartment is failing in our specific patient? Let's bring out the clinical tools. We can actually build this out into a highly practical clinical algorithm. We take this massive, complex differential diagnosis and turn it into a super clear, predictable 3-step flowchart. Step 1 evaluates baseline hormones. Step 2 tests the physical tract. And Step 3 pinpoints the brain defect. Step 1 starts off with a simple blood draw. We are looking for serum levels of FSH, LH, TSH, and prolactin. Let's say we get hypergonadotrophic results, meaning FSH is sky high, over 20, and LH is over 40. Well, that points the finger squarely at the ovaries in compartment 2. The brain is screaming at the ovaries to work, but they just aren't responding. Conversely, if we get hypogonadotrophic results, where FSH and LH are both really low, under 5, it tells us the ovaries are fine, but the brain isn't sending the signal. That points our entire investigation up to compartments 3 or 4. Now, if those initial hormones come back completely normal, we move right along to Step 2. We need to assess the level of estrogenization and check if the outflow tract is actually intact. We do a progesterone challenge test by giving the patient MPA, 10 milligrams a day, for 5 days. Then we wait 2 to 7 days. If she experiences withdrawal bleeding, great! We've proved compartment 1 is functional and the doors are unlocked. If she doesn't bleed, we have to move to a combined estrogen-progesterone challenge to confirm if compartment 1 is truly the defective link. Finally, if our initial blood work showed low FSH and LH, remember, we have to figure out if it's compartment 3 or compartment 4 to blame. We do this in Step 3 by administering GnRH directly to the patient. So the absolute crucial point here is watching how the pituitary reacts. If we give GnRH and pituitary gonadotropins increase, it means the pituitary works just fine, but the hypothalamus wasn't doing its job, sending the initial signal. That's a hypothalamic failure. If they do not increase, the pituitary is completely unresponsive, indicating a pituitary failure. And just like that, case closed. We've moved from the physical doors of the anatomy all the way up to the highest control centers of the brain. And it was all triggered by just one missing symptom. It is truly incredible how amenorrhea acts as a direct window into the delicate, interconnected balance of the entire human endocrine system. It shows us that in the human body, absolutely nothing operates in isolation. And honestly, that leaves us with a pretty provocative thought. If simple stress or exercise can completely rewrite the brain's deepest hormonal programming, what other physiological assembly lines are being silently altered by our daily environments? Thank you so much for exploring this 4-compartment framework with me today. Keep learning, keep asking questions, and I will see you in the next explainer.